This is Heidi Sawyer. I'm going to be talking about stimulants for adults with ADHD, dispelling the myths, and recognizing the risks. ADHD stands for Attention Deficit Hyperactivity Disorder. ADHD occurs in both children and adults. Adults are an important segment of the ADHD population. 1.5 million adults received stimulants in 2005, and overall adults make up to 32% of all stimulant prescriptions. Between 3 to 9.5% of children have received an ADHD diagnosis, and the number is fairly similar in adults. 4% of adults are diagnosed with ADHD. The severity of this diagnosis is considered severe in 40% of adult patients. And there are no gender differences in ADHD seen in adults. Now, this is different from what is seen in children. In children, ADHD is 3 times more common in boys than in girls. Children with ADHD often persist with symptoms into adulthood. Over 30% of children with ADHD continue to meet criteria as adults. A 10-year study of 215 boys with ADHD found that a very similar number, 35% of children with ADHD, continued to meet criteria into adulthood. On the opposite end of the spectrum, 22% underwent a full remission. Now, in between those two numbers, that left 43% of patients with some degree of impairment due to ADHD. Now, if you combine those two figures, the 43% with some impairment and the 35% meeting full criteria for ADHD, you can see that approximately 75% of patients are affected by ADHD to some degree into adulthood. The cost of ADHD can be quite high. A study of the national annual incremental cost due to ADHD found that up to $266 billion overall of increased cost in patients with ADHD was seen in comparison to patients who did not have ADHD. Of that number, approximately $194 billion was attributed to adults, and this is because most of the cost comes from losses in productivity and income, and of course that's going to be more common in adults than it is in children. A second study looked at the 9-year healthcare costs, and patients with ADHD were found to spend approximately $2,000 more on healthcare than those without ADHD. This is attributed mostly to increases in hospitalizations and ER visits. What are the symptoms of ADHD? Common symptoms include inattention, impulsivity, and hyperactivity. Now, symptoms of ADHD in adults can look a little bit different than they do in children. Hyperactivity and impulsivity are present in only 50% of adults, whereas an inattention tends to be the most common symptom. Inattention occurs in up to 90% of adults with ADHD. Like I said, ADHD looks a bit different in adults than it does in children. In adults, most common symptoms tend to be poor attention and concentration, easy distractibility, and frequent shifting of activities. Less common things include boredom and fidgeting and intrusiveness and impulsivity. Those are all things that you would expect more commonly in children. This slide again goes over some of those differences between symptoms in children and symptoms in adults. In children, you tend to see issues with poor school performance or discipline problems. Kids are 3 times more likely to repeat grades if they have ADHD than those without. And in adults, in contrast, you see issues with something called poor executive functioning. Executive functioning is an umbrella term for cognitive processes that regulate other cognitive processes. And examples of this include planning, attention, and being able to switch your focus. So if you have difficulties with these things, it can spill over into many other areas. For example, organizational issues can result, like difficulty paying bills, and you can also have poor time management. Another common issue with adults with ADHD is psychosocial impairment, and we'll talk about that a little bit more in a few slides. Occupational issues can also occur with adults. Adults can see lower rates of professional employment and frequent job changes, and all of that can result in lower socioeconomic status and a greater risk of homelessness. Driving issues are also fairly common, including license suspensions. And of course, if you don't have your license, it makes it more difficult to get to work and to keep your job. Social issues can also occur. Temperamental instability is common. Things like irritability and overreacting can often occur, and that can lead to other social difficulties. Patients with ADHD report having fewer close friends than those without ADHD. They have trouble keeping their friends, and they tend to have less romantic relationships and a higher rate of separation and divorce. Higher rates of criminal behavior are also seen, including higher rates of arrest and higher rates of conviction, and you can see those numbers on your slides. Patients with a current diagnosis of ADHD tend to have the higher rates of those two conditions. Those who have remitted ADHD are a little bit lower, and those without ADHD at all are lowest. Increased risk of substance use disorders can also occur with ADHD. Patients are 1.6 times more likely to exhibit alcohol dependence than controls, and ADHD patients tend to be overrepresented in substance abuse treatment programs, and they can make up to 25% of the population in those programs. And if you remember, the prevalence of ADHD in the overall adult population is around 4%, so that's a pretty big difference there. This slide goes over some of the common comorbid disorders seen with ADHD. Comorbid just means that another disease state is occurring at the same time as ADHD. Patients who have ADHD and comorbid psych disorders are at a much higher risk of having negative outcomes of their disease than those without those comorbid disorders. Most common comorbid disorder in adults is depression, and if you look at the data for children, the most common comorbid disorders are a little bit different. Oppositional defiant disorder, conduct disorder, and mood disorders are the most common. There are several different risk factors for ADHD. Having a close relative with a mood or an anxiety disorder is a risk factor for ADHD. Patients who have had brain trauma or intrathecal chemotherapy can develop ADHD, and this can occur in patients who have had no prior history of ADHD before the brain trauma or the chemotherapy. There also are some risk factors that are linked to events that occur during pregnancy. Maternal smoking, alcohol abuse, and exposure to other toxins such as lead are linked to an increased risk of ADHD, as well as fetal distress, prolonged labor, hypoxemia, and prematurity with birth weights less than 1,500 grams. And that is equivalent to approximately 3.5 pounds. So you can see that really is a pretty low birth weight. The biochemical basis of ADHD is differences in neurotransmitters in the brain. Neurotransmitters in the regulatory systems of the brain are linked to those problems with poor executive functioning. More specifically, ADHD is linked to altered catecholamine neurotransmission. Catecholamines are epinephrine, norepinephrine, and dopamine, and these are all secreted from the adrenal glands. Secondly, it seems that there is a large inherited component to ADHD, and the heritability of ADHD is estimated at 0.76. Well, what does this really mean? First of all, this is not an individual-based statistic. It does not mean that if your father has ADHD, you have a 76% chance of having ADHD yourself. Instead, this is a statistic that is based on population numbers, and it just represents how much genetic component as opposed to environmental component contributes to the development of ADHD. So in this case, we can say that there is a very large genetic component to ADHD. There are many other theories with little or no support to the development of ADHD, and these include high sugar diets, food additives, and vitamin deficiencies, as well as allergies. So there really is very little or no support for these theories. The diagnosis of ADHD depends in a large part on the patient's history and the chronicness of their symptoms. Now, the most important thing to remember is that a formal diagnosis of ADHD as a child is not required for an adult diagnosis. However, having said that, if there was no concern for ADHD in childhood, then diagnosis of ADHD as an adult is unlikely as well. Now, the slide here lists several different rating scales that approach ADHD from different perspectives. The first group there looks at childhood history, so the adult would fill out these forms about what it was like for them as a child. You can also look at the patient's past school performance, looking at report cards or maybe speaking to family members, and that is particularly helpful, especially if you suspect that somebody is trying to obtain stimulants who maybe really doesn't need them. The last group of rating scales there looks at current adult behavior. Most of these scales take about 5 to 20 minutes to complete, and their real purpose is for screening rather than ADHD diagnosis. The diagnosis of ADHD also needs to take into account psychiatric and physical examinations as well, and this is done just to rule out other causes for symptoms. Patients who have other psychiatric conditions may benefit from treatment of those other comorbid disorders first, or they may benefit from the treatment of ADHD first. It really just depends on the severity of symptoms and what is going on with that particular patient. The physical exam is part differential diagnosis and also part done to evaluate contraindications to the treatment of ADHD, and that's particularly true with cardiovascular disease, looking at hypertension and structural abnormalities. And this is simply done to evaluate the risk of adverse events when taking stimulants, and we'll get to that in a little bit. The DSM V Guidelines are a method of diagnosing ADHD. The DSM V Guidelines were released in May of 2013. DSM stands for Diagnostic and Statistical Manual of Mental Disorders, and it is put together by the APA, which is the American Psychiatric Association. Now, these guidelines replace the DSM IV guidelines, and there are a couple different places where the guidelines differ, and I'm going to highlight those when I get to them. First off, ADHD must be present in multiple settings in order to meet criteria for an official diagnosis. So for adults, it would need to be present in both social and occupational settings. Secondly, symptoms need to exist by the age of 12. Now, this is one of those areas where the new guidelines differ from the old. In the past, the DSM IV guidelines specified that symptoms needed to be present by the age of 7, but now that has been raised up to the age of 12. Next off, symptoms should not be better explained by any other mental disorder, and they should not occur exclusively in the course of schizophrenia or any other psychotic disorder. Probably most importantly, patients must be functioning at a level below those of similar age and educational background due to the symptoms of ADHD. Now, in kids, we would say that the behavior that they're exhibiting is not appropriate for their developmental age. But in adults, you just look for behavior that is a little bit different or below what is expected for their age or educational background. Now, one thing the DSM V guidelines did was to provide a lot of examples for what ADHD might look like in adults and how that differs from children. And I've included some of those here. So for inattentive subtype ADHD, some of those adult behaviors might be handing in inaccurate work, difficulty focusing during lectures or conversations, failures to meet deadlines, losing your keys or your cell phone, or forgetting your bills, or forgetting to return calls. Now, of course, all of us do these things, but the key difference is that a person with inattentive ADHD would be doing these much, much more frequently than someone without. Now, hyperactive or impulsive subtype ADHD might look for different symptoms. It's that feeling of restlessness, talking excessively, someone who can't wait for their turn in conversation or in line, or someone who may even take over what other people are doing. The DSM V guidelines require the presence of 5 out of these 9 symptoms in each of the 2 different categories for adults to be diagnosed with that particular subtype. Now, in children, the diagnosis requires 6 out of the 9 symptoms, so that's a little bit different, again, between adults and children. Now, one thing I wanted to mention was that the comorbid diagnosis of autism is allowed at this point with the DSM V guidelines. The DSM IV did not allow both diagnoses of autism and ADHD to occur, but that restriction has been lifted. I also wanted to mention that there has been some controversy about these guidelines. After the guidelines were released, the NIMH released a statement about them. NIMH stands for National Institute of Mental Health, and this is one of the main organizations that funds psychiatric research through the government. NIMH stated that they were going to move away from funding research that was based solely on DSM V diagnostic criteria. They stated that the DSM was a dictionary at best and not a Bible for mental health disorders. They questioned the validity of the DSM since it was based on clusters of clinical symptoms and not on objective measures. So they said that they would focus on funding research that looked across the DSM categories to patients who had similar symptoms but different diagnoses. So for example, instead of funding research that looked only at patients with a diagnosis of depression, they might look at patients with different diagnoses but very similar symptoms. So, for example, patients with both bipolar disorder and depression who had depressive symptoms. So after this statement was released, the press interpreted this as the NIMH denouncing the DSM V. But this actually isn't true. A couple weeks afterwards, both agencies issued a statement that they have shared interests and will continue to work together. So we'll just have to keep an eye on this and see where the controversy moves from here. I also wanted to mention just briefly that there are other diagnostic criteria for ADHD in adults. Probably the next most commonly used criteria are the Utah criteria, and these were developed specifically for adults. The weakness with this particular criteria is that they may not differentiate ADHD from other affective disorders, and that they don't do a great job of identifying inattentive ADHD. And that can be a problem because, as we talked about before, inattentive ADHD is the most common type in adults. Now we're moving on to talk about treatment guidelines. Now, overall, there are very few treatment guidelines for ADHD, and even less of them address treatment of the adult population. And of those few treatment guidelines available, none of them have been published recently, so we don't have a lot of good guideline data to fall back on. But I just wanted to mention a couple of these here. First off is the European Network for Adult ADHD guidelines that were released in 2010. These guidelines recommend the use of stimulant medications first line and the use of atomoxetine or Strattera as a second line agent. These guidelines fall into line with the main guidelines used for children, which are put forward by the American Academy of Pediatrics, and they also recommend stimulant use first line. That third guideline listed in the middle of the page, the AACAP, which stands for American Academy of Child and Adolescent Psychiatry, simply lists that adult and children should be treated the same, but they don't make any actual recommendations on medications, so that one is a little bit less than helpful. So what can you expect from stimulant treatment? Well, the main effect of stimulant treatment is to control the core symptoms of ADHD, which are hyperactivity, impulsivity, and inattention. ADHD treatment can also decrease issues related to ADHD like low self-esteem and anger outbursts and mood swings, but it will only decrease these. They will not be eliminated altogether. Now, the main treatment options for ADHD stimulant-wise include methylphenidate and amphetamines, and I'm going to go into detail about both of these classes of medication. Now, the mechanism of action of methylphenidate is to increase dopamine and norepinephrine. Remember that ADHD is associated with altered catecholamine levels, and these are both catecholamines, so that fits together well. Methylphenidate inhibits the reuptake of these neurotransmitters into the presynaptic neuron, and it increases their release into the extraneuronal space. So if you put both of those two things together, that increases the levels of dopamine and norepinephrine. Secondly, I wanted to say that kinetics are very, very important with these drugs and very, very important in the choice of medication. So we're going to spend some time talking about this in depth. But I wanted to mention that in general, there are two types of medication, two types of formulations of methylphenidate. The first is immediate release and the second extended release. And immediate release products tend to be dosed 2 to 3 times a day. Extended release are daily products. Now this next slide lists the available methylphenidate products on the market at this point. First thing I wanted to point out are the 2 immediate release products. If you look at the far right column, dose, you'll notice that there are 2 products highlighted in red that have 2 or 3 times daily dosing, and that is methylphenidate or Ritalin, and the second is dexmethylphenidate or Focalin. And those are really the only two immediate release products that are available on the market at this time, and they have fairly short durations, around 3 to 4 hours roughly. I also wanted to point out some basic differences between the rest of the products, which are all extended release products. First way to differentiate these is to compare those with continuous release to those with bimodal release. Continuous release products simply release drug at the same rate over the dosing interval. Examples of this include Ritalin SR, Metadate ER, and Datranap, and that is the methylphenidate patch. I wanted to mention that Ritalin SR may be a little bit more variable than most of the other products that we're talking about here today. You'll notice that the half-life is listed as a duration of 8 hours, And in reality, it may not quite last that long in most patients. It tends to be a bit patient dependent. Now, the second type of methylphenidate extended release product are those with bimodal release. And that simply means that the formulation has 2 peaks or bursts of medication released. And that's typically done through having a combination of immediate release and extended release beads in different concentrations in the product. Examples of this include Concerta, Metadate CD, Ritalin LA, Quilivant XR, which is a newer product that I'll talk about in a bit, and Focalin XR. I wanted to draw your attention to the middle of the table just to talk through some of the differences between these products. You'll see methylphenidate 50/50, and in parentheses, Ritalin long-acting, or LA. And if you look at that formulation, it has 50% immediate release and 50% extended release beads. And this produces 2 peaks at 1 and 4 hours after tablet ingestion. And that's dosed once a day. In comparison, you can look at the line above it and you'll see Metadate CD, and that has 30% immediate release and 70% extended release. It has those 2 peaks, but you're getting different amounts of drug at each time, and it has a little bit longer half-life. So you can see that depending on your patient's needs, you can play a little bit with the kinetics of each of these products and hopefully find something that really works well for your patient. I also wanted to point out the products that have the longest duration, and those are Concerta, Quilivant XR, and Daytrana, which is the patch. And these all have durations of approximately 12 hours. And sometimes these longer duration products can be really helpful for patients because they simply provide coverage for a longer period of the day, and you don't have to worry about needing to remember to take your medications and all of that sort of thing. So those longer acting products can be a real help to patients. Now I wanted to talk about a couple more products in a little bit more depth, and the first of those is Concerta. Concerta is an osmotically active tablet that has a tri-layer design. This includes an immediate release overcoating and 2 drug layers, followed finally by an osmotic layer. So water in the GI tract triggers this osmotic layer to expand and push out the drug. The onset of Concerta is about 60 minutes and its duration is approximately 12 hours, and the release of drug actually increases over the first 6 to 7 hours after ingestion. Now, as you probably know, the Concerta tablet does not dissolve, and sometimes this can be a little bit alarming to patients, but we just need to assure them that yes, it is still working, and yes, it's okay if you see it come out the other end. But the downside of this is that the Concerta tablet can increase the risk of GI obstruction, and this is something to be aware of in patients who have other risk factors for obstruction. Now, the next product I wanted to mention is Quilivant XR, and now this is an extended release solution, and it was approved in September of 2012. It's the first extended release methylphenidate solution to hit the market. It contains 30% IR and 70% extended release beads, and this is done by covering each particle with different amounts of a proprietary coating. So the thicker the proprietary coating, the longer acting that particular particle is going to be. It is supplied as a powder for reconstitution, and it is stable for 4 months once it's mixed, and it can be stored at room temperature, which makes life a little bit easier for patients. Next, I wanted to talk about the Daytrana patch. First off, since this is a patch and it's not absorbed orally, it has no first-pass metabolism. Now, if you remember, first-pass metabolism is metabolism that occurs in the liver before the drug reaches the systemic circulation when it is absorbed through the GI tract. And therefore, because this is a patch, it won't have that first-pass metabolism. So what that means for us is that a patient can be maintained on a lower milligram per kilogram dose of the Daytrana patch than they would be able to do with an oral methylphenidate product. So you need to remember that there's going to be a dosing difference there. Another important thing to remember is that there is a 2 to 3 hour lag between application of the patch and detectable methylphenidate concentration. So if someone needs to have the patch effective when they're heading into work, they need to be able to get up 2 to 3 hours earlier and apply it in order for it to be effective at that point. Peak concentrations occur at about 8 to 10 hours after application of the patch, and the patch is usually worn for about 9 hours on the hip. Now, a couple important things to remember about this patch is that absorption can be affected by heat and also by inflamed skin. So heat can increase absorption about twofold. So hair dryers and heating pads are the main culprits there, and you want to avoid that. Inflamed skin can also increase absorption by about threefold. And lastly, this patch cannot be cut. The last product I wanted to talk about is dexmethylphenidate, which is available as Focalin or Focalin XR. Dexmethylphenidate is an isomer of methylphenidate, and the dose equivalence is a little bit different. 2 milligrams of methylphenidate is equivalent to 1 milligram of dexmethylphenidate, so you want to keep that dosing difference in mind. Now, we've talked about a lot of different products, and this long list can often be confusing to patients, providers, and pharmacists alike. But there are a couple of different things you want to keep in mind. First of all, a longer acting formulation is preferred, and that's because it provides that better coverage throughout the whole day. But secondly, you may also need to provide coverage for a patient later on in the day. So for example, if a patient is taking a product that has an 8-hour duration, take it before they go to work, then they're at work for 8 hours, that product may actually be wearing off before they are done with work. And they may need to take a second, shorter acting product in the late afternoon or evening in order to be able to cover that last bit of work, the drive home, and any interactions with family or friends after that. Now we're going to move on and talk a bit about amphetamines. Now the mechanism of action of amphetamines is very similar to that with methylphenidate. They increase dopamine and norepinephrine, and they do that by inhibiting the reuptake of both and by increasing the release of dopamine through reverse transport. Now, this table talks about all the amphetamine products that are available on the market at this time. First thing I want you to notice is that the half-life with these products are much longer than those that are seen with the methylphenidate products. The shortest half-life on this table is approximately 9 hours, and the shortest half-life with methylphenidate products is around 2 to 3 hours. So that's a big difference. All of these products can be dosed once daily, although some patients will require BID dosing. I also wanted to mention the mixed amphetamine salts, and those are better known as Adderall and Adderall XR. Those are probably the most commonly used of the amphetamine products. And they are called mixed amphetamine salts because they contain dextro and levo isomers of amphetamine in a 3-to-1 ratio. Now, the main difference between Adderall and Adderall XR can be seen in the Tmax, and Tmax stands for time to max concentration. You can see that the XR has a 4-hour longer Tmax than Adderall does, and this allows for once daily dosing. The XR product is designed to be equivalent to taking Adderall on a BID schedule. Now, one last product that I wanted to draw your attention to is down at the bottom of this table, and that is Vyvanse. Vyvanse is a prodrug of dextroamphetamine, and it is linked to lysine. This linkage is cleaved by enzymes in red blood cells. So the kinetics of this product are not affected by GI issues like transit time or pH. And because of this cleavage in the red blood cells, Vyvanse may be a bit more difficult to abuse because it can't be converted into a short-acting stimulant product through grinding or dissolving as some of the other long-acting products can be. It also tends to have a little bit less interpatient variability in its kinetics, and the duration of action is quite long. It's between 12 to 14 hours. Well, the big question is, do stimulants really work in adults? At this point, we do have enough data to be able to answer this question fairly certainly, and I'm going to go over the trial results with both methylphenidate and with amphetamine. So first off, there's a meta-analysis of 18 methylphenidate trials in over 2,000 adults, and this meta-analysis found that methylphenidate was more effective than placebo, and you can see that by looking at the standard mean difference, that's SMD at the end of that line there, of 0.49. Now, the SMD is a statistical measure used to compare results that have different scales, and it's commonly used for results with a meta-analysis. The SMD is the number of standard deviations by which methylphenidate changes ADHD outcomes. So the larger that number is, the bigger the effect size. And in this case, the SMD seen in this particular meta-analysis had a medium effect size. Now, a couple other interesting things were noted with this trial. The effect size actually increased with the methylphenidate dose. So if you increased the methylphenidate dose by 10 milligrams, you had a bump in your SMD. The effect size also increased with non-continuous dosage forms, and that goes back to those bimodal dosage forms that we talked about earlier. That's things like Ritalin, LA, and Concerta. So those tended to have a bigger effect size than other methylphenidate products. Now, the trial the systematic review that looked at amphetamine trials also found similar results. Amphetamines were more effective than placebo, and the effect size ranged between medium to large. And another interesting thing was that the mixed amphetamine salts, that's the Adderall products, had a significantly lower dropout rate than other amphetamine products. Now, because this is a systematic review, we can't really address the question of why this was different. It could simply be patient preference, or it could be a difference in efficacy or tolerability. We don't really know, but it is an interesting result to keep in mind. Now, an even bigger question is which stimulant class is more effective in adults? We have some data to look at this, and I wanted to go through two different studies with you. The first was a meta-analysis of 18 trials in over 1,000 adults. And this trial found no difference in effect size between methylphenidate and amphetamine. It also found that the effect size was significantly less with non-stimulants than with long-acting stimulants. So that really supports what the guidelines have said, is that stimulants are more effective and should be used first line. Now, the second study was a retrospective database study in Texas looking at the Texas Medicaid program, which has over 15,000 patients. This trial also found no difference in adherence or persistence between the two classes of stimulant medication. Adherence was 44% less with the short-acting formulation than the long-acting, which just goes back again to the preference for a long-acting product. Although again, we can't really say what caused the difference in this because we don't have that level of data. While looking at these two studies, the question is which product should a patient start with? And this data does not truly answer this question. We don't really have data that shows that one class is any better than the other. But through clinical experience, we know that some patients do tend to respond better to one class than the other. At this point, we don't know why that is, and we can't predict which patients will respond better to which drugs. But we do need to keep in mind that this is true. So if you run into a patient who has had a decent trial of one particular class of medications, they've been on it for a while, they're on a good dose, they're being compliant, all of that is good, and they're still not getting a good result from it, you can always consider switching to the other class of medication, and they may respond better to it. Another important question to answer is the issue of long-term treatment outcomes. If you look at the package inserts for these medications, they will mention that these products have been studied for 3 or 6 or 7 weeks, but we all know that this is not the reality of ADHD treatment. Patients need to be treated for ADHD for quite long periods of time, years if not a lifetime. So the question is, will these medications work over the long term? Well, one recent study took a look at this, doing a systematic review only of trials that looked at treatment of ADHD for 2 years or longer. And this trial assessed outcomes of ADHD rather than symptoms. So that means that the trial was looking at things like social function or occupation rather than actual symptoms of ADHD. And the results of the trial were encouraging. First of all, and this is not rocket science, untreated patients do poorly. We could probably figure that out. 74% of studies found that those with untreated ADHD did worse than people without ADHD. Secondly, and this is basically the flip side of that first point, treated patients do better than untreated patients. So 72% of outcomes improved with ADHD treatment. Outcomes that improved the most significantly most consistently were driving, obesity, self-esteem, and social function. Outcomes that did not improve that consistently were occupational issues, run-ins with the law, use of the healthcare system, and antisocial behavior, which in this particular study was just a code word for criminal behavior. Lastly, the study found that patients who were treated still did worse than those who did not have ADHD at all, and that is unfortunate. But we just need to keep in mind that patients will do better on treatment even if they don't reach the levels that you would hope they would. They still won't compare to patients without ADHD, but they're still going to do better if they're treated. So the take-home point from this study is that stimulants have been shown to be effective at least out for 2 years, which is encouraging. At this point, we're going to shift gears a bit and talk about adverse effects of stimulants. First of all, I wanted to say that stimulant adverse effects, in the most part, are mild and transient, and you tend to see them when you're initiating a patient on a medication or when you're having a dose change. And common side effects are listed on that table on the left side of your slide. Abdominal pain, loss of appetite tend to be the most common. Insomnia, headache, and dry mouth often occur as well. On the right side of the slide, I've listed several contraindications to stimulant use, and I'm just going to draw your attention to a couple of those. First of all, both methylphenidate and amphetamine products have a contraindication to MAOI use within 14 days. MAOI stands for monoamine oxidase inhibitor. MAOIs slow stimulant metabolism and slow their elimination, and this acts together to potentiate stimulant actions. And this can lead to things as simple as headaches or as complicated and terrible as hypertensive crises and even death. So that's the reason behind that contraindication. I also wanted to point out that amphetamine products have a contraindication for patients with a history of drug abuse and also for patients with moderate hypertension and symptomatic cardiovascular disease. And at this point, we're going to talk about that in a little bit more depth. Now, this slide shows you the average increases seen in blood pressure and heart rate with stimulants as a whole. So systolic blood pressure can increase up to 5 millimeters of mercury, diastolic 3, heart rate up to 6 beats per minute. Now, these are the average responses. Some trials have found much larger increases. Recently, the Quilivant XR data has been published, and those trials have found that 46% of patients increased diastolic blood pressure by over 20 millimeters of mercury. So that is really quite a large increase in almost half the patients in the trial. Secondly, the trials also found that 22% of patients increased the heart rate by over 25 beats per minute. Again, that's huge. So you want to remember how important it is to monitor patients for their blood pressure and their heart rate increases when they are on a stimulant medication. Another thing I wanted to point out is that the FDA published a report of sudden cardiac death in 2007 that sort of began a controversy about cardiovascular disease and stimulants in ADHD. Now, there were 12 post-marketing reports of sudden death in patients who were receiving stimulants, and this data was put together through the FDA's Adverse Event Reporting System, or AERS system. And these 12 reports occurred both in children and in adults. In 5 out of the 12 reports, those patients had structural heart defects. So I want you to tuck that into the back of your mind that that's going to come up again, that structural heart defects and stimulants are a bad thing together. So based on this information, the FDA concluded that the rate of sudden death was slightly higher with amphetamine than methylphenidate. Then the FDA did a safety review, which assessed all reports of sudden death in the AERS system for stimulants over a 4-year period. So this was a much larger period. And the FDA found that the rate of sudden death was between 0.1 to 0.3 per 100,000 patient years for the two classes of stimulants. And again, it was slightly higher for amphetamines. But the interesting point was that both rates were below what would be expected as a background rate for these conditions in adults. Nevertheless, the FDA went on to add a couple different warnings to stimulant labeling. The first was that sudden death, stroke, and MI are reported in adults on stimulants, and that was added just so that the awareness would be out there that this should be a concern in adults who are taking stimulants. Second was not to use stimulants in patients with cardiac abnormalities. So that goes back to those structural defects that we were just talking about. You do want to be very aware of those types of conditions as well as cardiac disease, and those patients should really not be taking stimulants. And third, a black box warning was added for amphetamine products. And that simply stated that the misuse of amphetamines can cause sudden death and serious cardiovascular adverse reactions. Since that time, 3 cohort studies have been published to look at this issue in a lot more depth. And first of all, I wanted to say a few more things about cohort studies before we jump into what the results of those trials are. Cohort studies are observational studies designed to assess risk factors for a certain event, and a cohort is just a group of people that are followed over time. Now, the disadvantage of these studies is that confounding can occur and it might go unnoticed, which simply means that results might be influenced by something that the researchers didn't think to look at. The other disadvantage of these studies is that they cannot be used to establish the cause of something. only a randomized controlled prospective trial can be used to establish causation. So having said that, let's look at these studies. The first was a retrospective cohort study in over 200,000 adults, and it compared methylphenidate users to matched controls without ADHD meds. It didn't use propensity scoring, which is just a method of limiting confounding. The study found that there was an increased risk of sudden death or ventricular arrhythmia of 1 per 1,000 person years. Now, this is a 1.8-fold increase in the risk of sudden death or ventricular arrhythmia compared to patients without stimulants. Now, the interesting thing about this trial is that no dose response was seen. Now, you would expect that if methylphenidate was truly linked to sudden death or ventricular arrhythmia, that more methylphenidate would cause more sudden death. But that actually wasn't seen. Patients who are on higher doses of methylphenidate had a decreased risk of stroke, MI, and all-cause death. Now, the reason behind this isn't known. The researchers hypothesized that it could be that sicker patients were simply prescribed lower doses, but because this is a retrospective cohort study, we don't simply have the data to truly figure out what's going on with this lack of an association. Now, the second study was also a retrospective cohort study. It was done in a smaller population, and it compared Strattera users to stimulant users. Again, it didn't use that propensity scoring, but it did find that there was an increased risk of TIA. TIA stands for transient ischemic attack. So there was this increased risk with the initiation of ADHD meds in comparison to people without them. Now, if you look at the results of this study listed on your slide, I want you to look at the confidence interval. That's the 95% CI. And I want you to note that those numbers have a very wide interval. The lower bound is 1.13 and the upper bound is 10.6. That's quite wide. And what that simply means is that there is not a lot of certainty about the results of this study. And one last thing is that the study found that there was no increased risk of stroke with ADHD meds, which again is a little bit confusing since there was an increased risk of TIA. Now, the last study I wanted to bring up was also a retrospective cohort study. This was really the largest and the best designed of the three studies. It compared stimulant users to matched controls without ADHD meds, and the records of the cardiovascular events were adjudicated. And what that means is that the researchers went back and looked at the medical records of each of the patients who had a cardiovascular event to make sure that what the diagnoses of death really matched up with what was present in the medical records. This study found that there was no increased risk of serious cardiovascular events with stimulant use, and serious cardiovascular events were defined as sudden death, MI, or stroke. And if you look at that confidence interval here, listed here on the slide, you can see that the confidence interval is much narrower, so that means there is much more confidence in these results. Well, to sum this up, we had three studies, two of which showed increased risk of cardiovascular events in adults on stimulants. However, the best and the largest studies showed no increased risk. So what do we make of this? What's the take-home message? Well, at this point, we need to remember, first of all, that we don't have randomized controlled trial data, so we can't say anything about the cause of these things. We really would like better data. However, because this is a very rare outcome that we're looking at, doing a large RCT is very difficult and costly and time-consuming, and we probably won't have that data for a very long time, if ever. Next thing we can conclude is that there really does seem to be more risk in adults than there is in pediatric patients. Now, I didn't present the pediatric data, but just to sum it up, 6 out of 7 trials in the pediatric population found no increased risk of cardiovascular events with stimulants. Now, that's pretty different from the adult data, which found that 2 of 3 studies found an increased risk. So we can probably say that there is more risk of these events in adults than in peds. And based on that, it makes it all the more important to remember to monitor patients for heart rate and blood pressure increases, and really to avoid the use of stimulants in patients with cardiovascular disease. Now, the last thing I wanted to talk about is the risk of abuse. All of these substances, these medications, are C2s. All of them carry a black box warning of the high potential for abuse. How much does this abuse happen? Well, a study that was completed in 2006 found that there was a 3-fold increase in stimulant use from 95 to 06 and a 2-fold increase in prescribing in the US. So based on this, you can see that there's a bit of a disconnect and probably some non-medical use of stimulants going on. Survey data has also found that some adults are willing to admit to non-medical use of stimulants. A survey of 4,000 patients found that 2% of adults claim to use stimulants for non-medical purposes. And if you look at young adults between 18 to 25, that number goes up to 8%. Based on these surveys, it seems that patients most likely to abuse stimulants are Caucasian men, as well as those with a history of alcohol or illicit drug use. Well, what can we do about this? There are a couple different strategies we can use to prevent misuse and diversion. The first and most simplest is to have regular follow-up visits with patients. And that just simply establishes that relationship between the patient and the provider, establishes trust and opens up communication, and that alone may be enough to prevent misuse and diversion. Another strategy is written controlled substance agreements. Now, these are individualized, and the purpose is to prevent any misunderstandings and to establish that trust with the patient. And like I said, they're individualized, so the things I have listed here on this slide may or may not be present in that particular patient's controlled substance agreement. But some typical things would be to agree to only use one provider and one pharmacy, to not use any illegal substances, and that may include random urine drug screens. Patients agree not to share, trade, or sell their medication, and they understand that lost or stolen meds will not be replaced. Although in some cases, if a police report is provided, the provider may replace those lost or stolen meds. It just depends on that relationship with the provider. And lastly, prescriptions will be written only during regular office hours, and what that means is you're trying to eliminate weekend or evening emergency phone calls. Now, this agreement is, if it's broken, that ideally the provider would stop prescribing medications. And that really is the strength behind the agreement. If the provider continues to prescribe medications to someone who's broken their agreement, the written controlled substance agreement really doesn't have any strength to it. Now, the last thing we can consider with preventing misuse or diversion is the use of extended release formulations of stimulants. And this is simply because the risk of abuse is related to the route of administration. A rapid rise in dopamine levels is seen after IV use or inhaled use of stimulants. So extended release products will have a much less rapid rise in dopamine, means they're harder to abuse, and they produce less euphoria than other immediate release type products. And some of these extended release products are designed specifically to prevent crushing, such as Concerta and Vyvanse, and that, of course, will help to prevent abuse as well.